Good day, friends. I'm Dr. A.S.K. Gupta, and I'm going to talk to you about COVID 19 and the comorbidities, especially the incidence and complications of chronic lung disease in cases of COVID 19. As you all know, that COVID 19 is an acute respiratory disease that can lead to respiratory failure and even death. So, one would appreciate and anticipate that patients with COPD and asthma or other chronic respiratory diseases would be at increased risk of SARS-CoV-2 infection, and they will have more severe presentations of COVID-19. But is it true? Let us look at the data from various Asian countries like China, Canada, Taiwan, Hong Kong, India, and USA. This is the table which has the data from various countries about the prevalence of that disease in the general population vis-a-vis the prevalence of that disease in the patients of COVID-19. We will be understanding this in a pictorial manner in the next slide. Let us see what do we find over here. We see that in China, the prevalence of COPD is 6.9%, while in cases of COVID-19 it is only 2.4%, and in cases of Canada it is the prevalence of 4.9% versus 1% in COVID cases. In Taiwan it is again the same nearly, though the prevalence may be higher, and also in Hong Kong. This is the data from India, and this shows the patients who died of COVID, how many of them had what comorbidity, and you see that mainly the chunk is formed by the diabetes, then the hypertension, and the COPD is only represented by 20% of those who died of COVID 19. That is significantly lower than the diabetes and hypertension. What is the possible explanation for the lower number of chronic respiratory disease, that is COPD, asthma, interstitial lung disorders, as a comorbidity and in patients with COVID-19? While it is not so about diabetes in these patients, diabetes figures out to be a very prominent comorbidity, but not the COPD. Why? As we said in the previous slide, that the COPD represents lesser number of cases of uh, COVID-19 in comparison to the general population. So it is being said that the prevalence of COPD might be higher in general population than has been reported, and especially because COPD is a disease which may have an underdiagnosis and underreported in cases of China because they at times do not have any registry. So probably the data is wrong. Now let us see. It is true that the proper history may not be there in many of the Asian countries, but is it true about USA also? USA has a very strict monitoring of cases and reporting of various parameters. Let us look at the data from USA. This is the slide showing the incidence of COPD in patients with COVID, and this is the prevalence of COPD in general population. And you find that the prevalence of COPD in COVID is far less than the general population, even in USA, while the diabetes, on this other hand, has a similar prevalence as in case of general population as well as in COVID cases. So, what is the reason that the incidence of COPD is much less in COVID? To explain this phenomena, it has been postulated that the chronic respiratory disease protects against the COVID-19 probably through a different immune response elicited by chronic disease itself. However, this theory is not supported by the finding that among those with COVID-19 who have COPD as a comorbidity, mortality is increased. Had it been the immune response protecting them Why should they have a severe disease and higher mortality? So this theory does not hold true. Third hypothesis, which is being postulated, is that it is the steroid sparing effect. Most of these patients with COPD and asthma are on inhaled corticosteroids, and also in inhaled corticosteroids, either alone or in combination with bronchodilators, have been shown to suppress coronavirus replication and cytokine production in vitro models in some studies. So it is possible that these inhaled corticosteroids are helping these patients. Low quality evidence also exists in a case series from Japan in which the improvement was seen in three patients of COVID-19 who required oxygen but they were not on ventilator support after they were being given inhaled corticosteroid, that is cyclosonide. Yet the possibility that inhaled corticosteroids might prevent at least partly the development of symptomatic infection or severe presentations of COVID-19 cannot be ignored. However, in contrast, it has been seen in a systematic review that use of systemic corticosteroids to treat SARS had shown no benefit but possible harm. So we do not know what is the reason that the COPD is not a significant comorbidity in patients with COVID-19. But whatever it is a good news that these patients are protected, maybe by some unknown mechanism. However, this much inference we can draw from this data that no changes to the management of chronic respiratory conditions, including inhaled corticosteroids, should be considered with the fear of developing COVID-19 in patients who are stable, and the medicines should not be tapered or withdrawn with the fear of developing COVID-19. Thank you very much.